this is something I should say out loud. The strength and conditioning world thinks that your core is at least a 3 out of 5. Almost everyone who comes to me with some kind of chronic complaint is closer to a 1 out of 5. So that means that most of those exercises are completely inaccessible to you. Like you're going to try them, but they're not going to feel probably like your core. They're too hard.
All right, welcome everybody. I am Isabel Spradlin of healmybelly.com, which has always been abdominaladhesiontreatment.com, was just sort of going through like trying to make it more accessible to people. And as you know, over many years, I've done interviews with other practitioners to help bring more information than what I have as an individual practitioner. And so I'm so thrilled to be here today with Jessica Corman. So Jessica Corman is the founder of Balance Portland, a Portland-based physical therapist specializing in core-focused rehabilitation and whole body movement. Her work centers on helping clients build strength, coordination, and stability from the inside out, with a particular emphasis on the deep core system and its role in supporting the spine, pelvis, and hips. Drawing on her background in manual therapy and movement analysis, Jessica helps individuals reconnect with their bodies, resolve persistent pain, and develop resilient, efficient movement patterns for everyday life. Jessica, you fit right into what my clients always need. And we've known each other for a long time. I send people, because we're both in Portland, I send people to you with great regularity. And it's just really a joy to be interviewing you today. So Jessica, do you just want to give us like a little bit of background about how you started this work, how you came to this work?
Mostly I came to this work through personal experience. I didn't know what a PT was until college and kind of got some friends and co-athletes who were like, I think you would be really good at this work. And then maybe ironically, maybe the universe was telling me things. I got an injury in my sport, which was ultimate frisbee. And it was a pretty debilitating injury that then led to chronic pain that lasted for about 10 years and was pretty terrible during PT school. But I think it was that experience that helped me understand the experience of chronic pain. I learned then that I'm hypermobile. That's a population that I really resonate with, especially with PT being as movement focused as it is, actually misses a lot of the ways that hypermobile people can move. And I figured that out through firsthand experience with PTs who didn't understand how to help my body.
Yeah.
So yeah, mostly personal experience. And that stuff still rears its head. So there's like such a nervous system component of protection and memory that I think sometimes is like a important piece that is often forgotten or missed in a lot of more standard practices.
And as you know, my clientele are pretty exclusively abdominal clients. Most of them, not all of them, but most of them have been through abdominal surgery, usually more than one. And they experience a lot of destabilization. One of the things that I have, and hopefully we can talk about this as we go, one of the things that I have become more aware of in working with you and another PT in Portland is this issue of hypermobility. And it's become really clear that a lot of the folks who really struggle with their abdominal adhesions being symptomatic are also on the hypermobile spectrum. So we can dive into that now or as we go, but I'm curious how you think about sort of this particular population of post-abdominal surgery folks, and how do you think about re-strengthening after surgery?
I mean, the first thing that comes to mind is I wonder how they got to the place of needing surgery. I know that in my patient population, I treat a lot of people who have endo. So I like to think about all the ways that the body was adjusting for whatever that state was that required the surgery, because that really informs how their muscular system is going to show up. Particularly if it was pain, I find that then tapping into those systems is even harder just because that has become kind of off limits. So something about the body that's like kind of annoying, but is part of our evolution is that when we have certain pain, our core muscles tend to go on vacation. I call it. They like take a super break. And that is really helpful in the initial phases of healing, but it is certainly not helpful in long-term healing. And then I think a lot of the people that you might see, the people that I see, end up on top of that system that's already been so disrupted. Then they get this surgery. And even though we believe that that surgery was necessary and there were things that needed to happen, in terms of how I think of the musculoskeletal system, it's like one further offense away from being able to actually reconnect and get the tissues to respond as they were designed to respond, if you will. And so if I actually see it quite similar to birth trauma too, right? Like, so the pregnancy is this like really weird, different experience that you could kind of say is what happens when we have a lot of pain. Our body just operates on a really different level. And then you're trying to get everything back. Like, what does that even mean? So that's where I think there's like a, it's interesting to think about what was going on before the surgery, because that's kind of like how I understand how people talk to their bodies. And I can then help understand like why your body maybe made some accommodations, really. It adapted. It was being super helpful. It was doing the best it could. But that's really frustrating when you're in a lot of pain and you're feeling unstable. So then slowly but surely trying to figure out, how do we talk to those muscles? How do we talk to those muscles without triggering a pain response? Are those muscles actually not even able to be accessed because of adhesions? Or I would say mostly adhesions is actually something that I think is driving sometimes a inability to get muscles to connect, especially when you're thinking of a hypermobile person, because if they have a, like, the more rigid the scar tissue is, the harder it's going to be for that person to use something other than that, because the system around it is so flexible. Does that make sense? Whereas if you have tissue that's a little more rigid, a scar might not be quite as meaningful or not as bossy, is kind of how I say it sometimes, where in a system where I tell people you're like 18 ways that you could move each joint, where most people have like one or two. Well, then that scar tissue might make those 18 ways over here instead of also over here, or however you want to kind of think about that. But in the belly, scar tissue is super tricky, because abdominal work is super tricky, because you're not only dealing with organs, but you're also dealing with pressure management and breath management. So
Yeah.
really long-winded answer to your question, but I think core work is like really my passion.
Yes, which is why I wanted to talk to you. And everything you just said, like each piece of what you said triggered something in my mind. And I was like, we have to dive into that. We have to dive into that. And then 3 hours later, we're still here. So just to touch a little bit, just to tie it back to the last interview I did with Cindy Dobroska last week, I talked to her about nutrition, but one of the things that she brought up was there are so many things that we can do to support the body. She really only focuses on working with people with endometriosis, but so many things that we can do to support the body, both pre and post surgery. And yet, once those pain patterns get kind of written into the system, often it requires more than nutrition, more than like the hands-on that I do. And this is what I see, which is why I want to interview everybody. And I really, everybody's question is, well, how do I eat to make sure I don't get a bowel obstruction? And how do I start regaining strength? Because regaining strength after surgery, particularly if you're hypermobile, even if you're not hypermobile, but this, as you said, the scar tissue has kind of taken over, has become very bossy. Like, not taken over in terms of overgrowth, but it's just, I love that. I'm going to start using that. I'm just stealing that from you, Jessica.
That's great.
But that scar tissue has started to get really bossy. And you also have this sort of nervous system cascade that every time you try to access the muscle, even just through, as you were talking about, like the pressures in the body that happen when we breathe, so many of our breathing patterns become compensatory in chronic pain. Or even just in restriction, even if that restriction is not necessarily causing pain, or it's not a pain that we're registering particularly. So all of these things play into, the restriction itself, like in the bossiness of the adhesions, the pressures as we breathe, as we move, that gets written into the nervous system, and it can actually create this loop that is very, very difficult, a loop of pain that's very, very difficult to break, or to interrupt, or to rewrite and to kind of nudge in a different direction. And then particularly if it's layered into a pre-existing hypermobility, all of that becomes really, really complex. And I really wanted to talk to you because you really understand the complexity of how the body responds. And I guess the last thing I'll say, and then I would love to have your response on any of this, or I can direct it into a specific question, is that, you know, as much as we're talking about the complexity of it, that doesn't mean it's not possible to resolve in a fairly straightforward way. Right. The complexity of it means it's complex, but if you're taking all of that into account, like, you can actually make progress. And you and I see this all the time. So I just wanted to throw in, as we're talking about all of this, it can seem really overwhelming or even feel really overwhelming. But there is, you know, what I'm trying to highlight by interviewing you and Cindy and the others that will come is that this is really workable.
Yeah, I mean, I think my response is, I think everything is important. I'm kind of like you. I think there's just, the complexity is simultaneously overwhelming. And I think as a person receiving this care, understanding the complexity is such an important piece, so that you understand the why of how challenging sometimes the rehab can be. And I really like to think of it as, the body was doing the best thing it knew to do at the time with the tools that it had. Because so many people end up in this pretty negative headspace about what's going on in their body. And I might call this quite woo. I think I've really become a lot more woo in my years as a practitioner, but I don't think we can really fully rehab tissue that we don't love, and that we don't accept where it's at. I think it's, for me, I guess, like, trying to help people find the silver lining of, oh man, I had this pain, or I had to have this surgery. And it's like, yes, and now you're getting this like fresh take on talking to your body in a way that if you'd never had these things, maybe you would have never learned. And maybe your system would have worked well, but I don't know. I kind of believe that most people have some kind of body crisis at some point in their life. I tell my younger patients that when you have it younger, now you're like sort of paving your path for when you're older to at least like know how to tap back in. I mean, I feel like that's a lot of what my work is. It's just like, okay, now this is the state. How do we get connected again? And there's so many things that are like, I can't even know what all things are going to be important. But my role is, can you talk to the tissue? Because if you can't talk to the tissue, it doesn't even matter kind of like what adhesions you have or what else is going on. I don't believe that you can just like get rid of that scar tissue and then like magically everything's going to turn around. So for me, putting that like top-down approach is actually helpful. Like, how do I talk to my core? You know, everyone's like, oh, it's just supposed to automatically function. And like, yes, in the most ideal case, it does automatically function. But let's say it doesn't. Now let's give you a strategy so that you have something that you can actually go back to as a scaffolding and be like, huh, my core isn't working as I thought. Now I know that. So now I can start to make some more informed decisions about how I want to move my body so that I don't hurt myself. Because I think there's like a really common, what we call like a boom bust cycle, where once you kind of have an injury and you're like, okay, I'm going to heal, I'm going to heal, I'm going to heal. And there's often like this period of time that we believe we're supposed to be healing. And then we're like, and then I'm better. And surgeons often really reinforce this like before and after situation that I just think is like not really helpful as the patient. Where we're not just before and aftering it. We're like, what are you doing in the meantime? How do we build? How do you, maybe you release a huge adhesion. How do you then talk to your core once that huge adhesion that was totally bossy is no longer there? Like sometimes that's almost a really unfortunate experience for people, because now that adhesion that had been holding them together is no longer holding them together. So then it's like helpful to have something to help your body go, oh, this is how we move now without that. That all kind of
Yeah,
makes sense.
it does. And so when you have somebody come in, with complexity, where do you start?
Hmm. I mean, it depends a little bit on what's going on. So if someone is like just figuring out that they're hypermobile and they're in a super flare, um, we start with breathing. And I usually don't touch them because the system is too upregulated for hands-on work in my experience to not just feel destabilizing. Um, that's my take. I always break my rules, but sometimes then I make people worse, and so I don't like doing that. But breathing, um, yeah, depends. Occasionally, and this is the benefit of where I tend to interact with people, people aren't necessarily always in the peak of their pain, but like something has just been stewing for a super long time, and maybe they're in like these like flares and remissions.
Mhm.
Then I often start with hands-on work, especially if their alignment is really funky. Because what I know about the muscles is that when the alignment is funky, it's harder to get a muscle to fire as designed. So lately that has been visceral work. So I do hands-on work that can really go to any part of the body, but now I'm skilled in actually moving the organs around. And what's wild when you talk about like things that you don't realize are influencing you, it has been such an eye-opening experience for me to feel the body sort of like tells you where to work, which is a total woo situation. But um, feeling that an organ can't move, it's really wild sometimes when you get it to move, that then the person is like, whoa, now I have access to my diaphragm in this new way, or whoa, now I have access to my rib cage or my core. So now there's this opening, right? There's this like moment where the nervous system is sort of more curious. And then that's like probably my most common way of interacting with people is we maybe free up some alignment restrictions that have been present for who knows how long. And then again, we then come right to breathing, which is my foundation for core work. So that we're doing more than we know is what my visceral instructor always says. Because if you change the pattern of the way someone breathes, you are now changing something that happens 14 to 17 times a minute. So the ripple effect of how changing breath is going is like the sky is the limit. Right now, that person is going to breathe how many times before they see you again? And that can actually loosen up all those other tissues that were potentially impacted by the breathing not being able to be full, or however you want to say it.
And so for people who maybe pre-surgery, and now they're post-surgery, and before their surgery, they were very active, either athletes or very involved in Pilates or yoga or strengthening, things like that. And so they come out of surgery. There's inevitably the sort of cooling off period where your body just has to
Mm-hmm.
take a minute, right? And by a minute, I mean like a month or 3 or 6. And for the folks who are really active, that is
Mm-hmm.
really difficult to tolerate, that period of time in which you have to just let things cool off. My clients, by and large, are accepting of that. They're like, yes, I don't love it. I know it has to happen. And yet, like, help me think about how, the question I get as we're working with adhesion prevention, or we know they already had adhesions and we knew it, the surgeons confirmed it. As soon as is safe after surgery, we're working on it to try to like make use of this initial repair process in the body, which can often be really supportive of releasing a lot of that adhesion. We're making progress in the tissues, and they're starting to feel better so quickly. They're like, I'm ready to start. I want to go back to Pilates. I want to start doing my core strength again. I want to start running again. Even if it's just like a little jog here and there. All of these things are very impactful to the body. And so how do you counsel people through that period when the answer often is extremely tiny steps, or what feels like extremely tiny steps?
I mean, I think that the you and I are kind of on this same journey a little bit because I think that people should be doing core work in that cool off period, but it's not going to feel like core work. It's going to feel like breathing fully. It's going to feel like interacting with, if we're talking specifically post-operatively, it's going to feel like breathing into spots that feel super vulnerable. But as you said, that's a time where things are really open to change. Like things haven't laid down yet. So to me, I want to interact with that tissue as soon as possible. Surgeons tell people all the time, don't go see your PT until minimum 2 weeks, maybe 6 weeks. I tell people that we don't need to usually adhere to that restriction because if you are walking, the core work I'm giving you is less than walking. So unless you have an activity restriction that is bedridden, and then we can meet online, like you can do this core work because you need this core work to get on and off the toilet, to walk around, to be able to stand, to tolerate making food. So much of it is actually helping the system rewrite how to talk to the tissues that have been really disrupted by surgery so that you don't develop a funky pattern, especially when you're ready, right? Because that's kind of what we were talking about that before and after, and I think I kind of lost my train of thought there, but like everyone's kind of like willing to accept this, I call it the protect and defend phase, where you're just really careful with yourself. Mm-hmm. And to me, that's the perfect time to do low level core work because that's where your mental state is. You're thinking about how much water you're taking in. You're thinking about the healthy foods, right? But you get to that period of 6 weeks when you're supposed to be cleared, or for a lot of my surgical post-ops, that's the date, right? And you can't, to me, it's nuts to think that you can go from like, I'm caring for myself, I'm going on gentle walks, to like, I'm going to try running. From a body perspective, that is like wildly different demands. So I like to, if I can, interact with people as soon as possible so that the baby steps aren't frustrating when you're at the point of being like, okay, I'm ready to actually get back to my activity. And then, people come to see me and they're like, you're saying my core's operating at a level 1 out of 5? And I'm like, yeah, it's a 1 out of 5. And they're like, should I run? And I'm like, when we get to level 3. And so there's like, I guess like to answer your question the most truly, I test people's core. I have a really objective way of testing it. And if you're not at a level 3, you probably shouldn't be doing anything high impact, which is like both feet leaving the ground at the same time. And then I also think about like what's happening at your pelvic floor. So if that's a part of the puzzle, like making sure we include that, because I think that also gets really disrupted with, most of the abdominal surgeries probably have some pelvic floor component, even if they don't know it. But even a surgery in general, like getting catheterized can be a really traumatic situation for the pelvic floor. So just a kind of tangent, but for me, pelvic floor is part of the core. So making sure that we're doing the painstaking, sometimes annoying work of like making sure the pelvic floor is participating even at those low levels with the core. Because to me, I'm a very linear thinker, but I love that idea that we can kind of see like, okay, you're at a 1. Great. Usually within like, really depends. But if you're consistent and there's not a lot in your way, within a couple weeks, we should see that you can progress to close to a 2. When you get to a 2, the level to 3 is usually a little longer because that's true muscle adaptation. So that tends to take a little more like 4 weeks. But a lot of the early phases of rehab are about coordination. And coordination is just about doing it over and over and over. I tell people it's like learning to play an instrument. You don't get better at it by looking at the instrument. You get better by just time spent.
That's great. I love giving people like some sense of what that timeline can look like once you've started working with it. Because one of the other things that happens is I have people come in with extremely historical surgeries, like multiple pretty intensive surgeries that happened 15 to 30 years ago. And so they're not in that immediate state of rehab. Their bodies have been helping them out through this whole time, and now they're ready. They either have the time or the wherewithal, or they just finally learned that they can actually help themselves with all of these issues that have come up over time. likely as a result. They really tie it to, I had these surgeries and just kind of
Yeah.
never did anything with it, and now I want to do something with it. And so, would you say for those people that there these rearrangements of how their body is kind of working as a whole, that it's really historical? Does the timeline of like that initial 2 weeks and then another 4 weeks, does that tend to play out as well? And I'm not looking for a hard and fast answer. I know this is not straightforward, but in general, like, what do you see there?
In general, the answer is no. It doesn't play out in the same timeline because, honestly, actually, so I test both core, and then my core testing is simultaneously testing how much compensation is being done. And the compensation can be kind of anywhere. One of the most common ones is a breath holding strategy, but if someone is that far out from the thing that they think kind of like was the thing that turned the corner towards the not great way that their body is acting, we basically know that they've been adapting and using some amount of compensatory strategy for a long time. So, yeah, it depends on, I would just say, the coordination piece in that timeline ends up being the thing that determines how quickly we move. So, how difficult it is to talk to the core is really,
And by talk to the core, can you, is that
yeah.
in your testing? Is that in your,
So when I teach core, I'm teaching a resisted exhale, and I'm basically looking for range of motion is how you can think of it. So like if someone was looking at your bicep, they would sort of see like, can you straighten your arm? Can you bend your arm? The core is kind of funny. It's like, what's fully relaxed? What's fully contracted? Honestly, I feel like I know that mostly from years of watching people's tummies move.
yeah, yeah.
Um, and I have learned to actually grade, like I do a resisted exhale, so like a exhale, and I'm looking, how does the tissue shorten? Because that's really what's happening. And sometimes it can only shorten like 20%, sometimes 50%. And that's something that we then just work on initially. And that's not even fully talking about coordination. If that makes, that's like if your coordination is good, then we can see what your range of motion is. So, I mean, I think what I often tell people is, so I had a back injury in my 20s. It took me 8 months of regular PT to find my core. And it was a very frustrating experience. I mean, I think that I was incredibly stubborn. The PT I was working with didn't do hands-on work. I think hands-on work would have worked really well for my body to help accelerate that process. But I was an athlete in my mind. I had a great core. I could do a 4-minute plank. And yet, this person was telling me that I didn't know how to contract my core at the most basic level. I honestly didn't really believe her. I mean, clearly I believed her enough to stick with her for 8 months, but I didn't really understand until I felt my core. And then I realized, oh my gosh, my inability to talk to my core actually like predates that injury to like, I don't even know when I last actually felt my core, which is when I understood that I was hypermobile, because that's like I didn't have like a surgery, and I didn't even have a big fall. I had a repetitive strain injury. And I think that, it still can happen to someone with like normal tissue tension, but it's less likely. That to me is like a hypermobile pattern. So I think what I find with working with people who've had long-term stuff going on is usually we don't just work on the core. We work on the compensatory strategies too. And so we work on like so my version of stretching is usually using some kind of tool, because I don't think that you can usually stretch tissue that's compensating, because the tissue that's supposed to be fighting it is the tissue that doesn't really function. But basically then we kind of think of it from two ways, like what's working too hard, how do we get it to work less, and what's not working hard enough, how do we get it to work more, so that we start to see a balance of how how we were designed to move. We were designed to move from a core first strategy. That's our biomechanics. But some people start to move from like a hip first strategy, and that tends to aggravate both the hip and the back. So how do we kind of calm that down while we bring this up? So once we move from level 1 to 2, then I usually know how quickly it's going to go. But that initial, like, how long does it take you to get through the level 1 is the like greatest wild card in that early rehab, because it's about practice, it's about daily practice, it's about time. And then it's like, seeing someone like you, like, how do we like break up the tissue that has been in these compensatory strategies, not even thinking like, I mean, like, I care about alignment, but it's also just like, how do we like refresh it? Let's just like give it a makeover so that we can actually come in with curiosity instead of all these like prefab ideas.
Yeah. And I think we'll end on this question because we've covered so much ground. Hopefully, this is giving everybody a ton to think about. But I've been encouraging people to come in for abdominal sessions in the months before they know they're going to have a surgery. So a lot of times the surgeries are a known quantity. They're for a specific reason that is sometimes life-saving, often life-saving, or it might be elective, but they're in so much pain, it's sort of like, I just have to try this. As endo has become increasingly better diagnosed, we're seeing people on the earlier end of that go into surgery, which I know there's lots of thoughts about this, but I've actually seen that really benefit people to be diagnosed earlier and have just more options earlier on in that process. But for all sorts of different reasons, whenever somebody knows that they're going into an abdominal surgery, I really encourage them to think about learning how to do the hands-on work for their abdomen themselves and doing it regularly up to the surgery. Or coming in for sessions. And, I've have multiple clients who have seen through multiple surgeries, and they generally, no matter how well we've worked through the last surgery, they will often get themselves on my schedule 2 months prior to their upcoming surgery because they know they want those tissues to be as supple as possible to make the surgery go as easily as possible. That is one thing we know in the literature, that the more adhesions there are, the more complex the subsequent surgeries can be. And so in terms of, and now I never knew the word for that, prehab. Yeah, and it's not even a full prehab, of course, but it is a form of prehab. It's kind of a piece of the puzzle of prehabilitation, getting your body ready for this rather extreme intervention.
Yep.
And feeling like you're going in robust and like you've kind of set yourself up for success no matter what happens in the surgery, because that's always a little bit of a wild card. And then, we have stuff we know we can do afterwards. But talk to us a little bit about prehab.
I mean, I think as much as you would do prehab for the tissue being supple, I would argue that doing abdominal work is part of what keeps the tissue supple. I mean,
Yes, I love that.
I don't think that core work can get rid of scar adhesions necessarily, but
And would you define core work as you're talking about it, just so we know?
what do I define? So using your core as designed.
Okay, thank you.
And that's, I mean, I have been in so many debates with so many different providers about what the core is and when should it work. And there's a lot of thoughts out there. But for me, I'm specifically looking at basically, can you stabilize your spine while you are moving a limb? If you cannot stabilize your own spine while you are moving a limb, your core is not functioning as designed. So that's like some of my objective measure. And if even going into a surgery, some of that is funky, abdominal surgery is going to pump you full of air, fluid. You're going to have catheter, like there's so much that changes the muscular wall that of course you're going to come out a little confused. So to me, and I also say that to my pregnant folks because their
Yep.
core is being stretched more than it's ever been stretched in its life.
Yes.
So if we can get that coordination piece going before all of that change occurs, then the rehab post-op is so much easier because you have a sense of what was basically, you kind of have a sense of what happened in that moment of either the pregnancy and birth or the surgery, because you try to do the same thing. And most people tell me, like, whoa, it was so hard to do it post-operatively. I'm so glad I tried it before. I mean, I don't get that many people who I get to see in that way, but I think it gives a sense actually too of how aggressive surgery can be for your body. Like we can kind of we believe that surgery is safe and like you said, life-saving intervention. And I think we also want to hold space for it's a really orthopedically challenging intervention for how do we then map afterwards? Your abdominal wall maybe didn't know that you had a bowel obstruction, but like then it was like, what? I was just doing my thing. And now like I got all this, who came in here and rearranged and moved me into a new apartment and I don't like it. And, so like we have to then like get that tissue to be like, okay, I know we moved, we changed the curtains, everything's new, whole new decor, but like we can get it. We
Yeah.
can find common ground. We can um get back to I like hate the phrase like getting back, but basically like getting more connected to your body is often how I say it, because all these interventions, they change us forever. And we're just
Mhm.
looking at now, what do we do? Now, how do we talk to those muscles? Now that the thing that was offensive is gone, or the thing that needed to happen happened. But either way, you still have to learn how to talk to that musculature.
Mhm.
And I think I mean, what I often tell people too is like in those first 2 weeks, especially post-operatively, even getting in the car to come to an appointment is usually pretty daunting. So if you have something you could just be working on that's just as simple as breathing, wouldn't that be nice to feel like you're doing something, you're making some progress, and you already have the muscle memory actually for it because you practiced it, so that it's not like now you've got all these new hills and bumps, if you will. But you still have like a sense of the landscape. Does that
Yeah.
make sense?
Yeah.
I
That
think
makes
prehab is like just still severely underutilized, but I think that that's because it's really hard to convince someone that things are going to be really different until they experience that it's really different.
Yeah, and for even those who are convinced and are really worried about it and concerned about it, it's not written into our healthcare system in a very
No.
effective way. And so you're not going to hear it, you're rarely going to hear it from your surgeon, you're rarely going to hear it from a PCP, you're rarely going to hear it, honestly, even from other healthcare providers. And so I wanted to make sure that we talked about prehab today because I think we have a similar commitment to it and a similar sense of how much it can help.
Can
And
I say
so
one more thing on that point?
please do.
I mean, I think what's interesting is that we have come to accept prehab for total knee replacement, total hip replacement. I mean, total knees in particular, I don't think you can usually get away with a surgery without doing prehab. And to me, that's a joint where like we can tell what your range of motion is. We can see when your knee is straight. We can tell when it's bent. You can watch the muscles move. It's so helpful because you can like test it and you can put a little electrode on it and you can even tell it how much it's working. The abdomen is like the Wild West by comparison. So to me, I think I want there to be a future where all surgery has a prehab, and all surgery has a post-op rehab. That to me, the fact that people who get ACL repairs or reconstructions, they're like, of course I'm going to commit to 9 months. Like that's actually part of the surgery commitment is you have to commit to 9 months of rehab.
Yep.
And some of the people are even getting prehab. It's not as common, but I see it. And yet for an abdominal surgery, we're like, we don't even think about it. It doesn't even make
Right.
sense.
Yeah, it boggles my mind. And one of the things that I, of course, am focused on because of my also training in the lymphedema world is that because the knee arthroscopies, replacement, just basically anything you can do to a knee joint, it's been studied really well. There's a lot of really good science and that supports everything that we're talking about. And one of the things that we have seen come out in the last couple years is a really great study about a specific kind of compression with this stuff called edema, where it's like a fuzzy whale construction compression that when they studied, is this better than like a regular form of compression over the knee after surgery? Turns out, yes, this fuzzy well constructed compression that was made initially for lymphedema, you put it on a post-surgical knee and bam, like I mean it's not like a solve everything problem, but it is a really powerful tool to have in your toolbox. And so we do this for a knee, which is really important to walk, to move about through the world. And then somebody goes in and has a bowel resection. Part or all of your large bowel is removed. You have a gallbladder removed. You have organs removed from your body or repaired. They go in, and as you said, there are these huge interventions if it's not an open surgery, which it rarely is these days. If it's laparoscopic, you're pumped full of the CO2. All sorts of different instruments are inserted and used and then retracted, and the air is forced out to the best, and then your body has to reabsorb it and all of this. And the aftermath of that is, okay, we'll see you in 6 weeks for your surgical follow-up. Don't lift anything over 5 pounds. And it's just like, it makes me just like, what? And so one of the things that this is my area, right? Like, so I just got really heated up, like physically heated up. I feel myself flush and I'm just like, we have to fix this. But yes, so I really appreciate you bringing all of these things forward. And like, as much as I know we agree on all of this, it's always so like such a wonderful surprise to hear you speak about it with such knowledge and such clarity. And I really think that it's so helpful for my clients, people in my programs, other people out in the world who are just finding this information, to hear it from more than one person. Because there are more than one of us who know this information.
I think you pointed out something that I just wanted to piggyback on, which is it's like in the PT world, part of like knowing how to talk to muscles is learned from people with neurologic dysfunction. And so, it turns out all of us have a nervous system, and we're really kind of grading sometimes our intervention based on where you start. But man, when you give people all the tools, I mean, if you really asked me, and this is maybe like spiraling a little bit, but if you get an abdominal surgery and you don't do any kind of prehab or rehab, you're probably going to get a total joint replacement, because it turns out your joints rely on your core to be stable. So to me, there's like so much that we're not yet even like looking at about like, how did we get to that place where that total knee needed to happen? Oh, wait. To me, I'm always like, you had a total knee rehab or prehab and no one looked at your core. But,
this is where I think we could just keep talking for 3 hours. We have so many things to talk about, Jessica. We'll be back. We'll do this again.
Okay.
Thank you so much for being here. I just want to ask you, is there anything else that you want to wrap up with before we end our conversation?
I would just say, if you feel, I say this to people all the time, if you feel like you're trying to do core work and it doesn't feel like it's core work, it's probably not core work. So find someone who can help you.
Phenomenal. And speaking of which, how do people find you?
So I'm in Portland with Izzy. I have a practice that is just me. So you can find me on the web at balanceportland.com. My name is Jessica. You can email me at jessica@balanceportland.com. But my website has all the ways to schedule or contact me. And I'm always happy to I talk to people on the phone all the time, because sometimes people think that they're ready to work with me, but there's also someone else on the team who maybe is more important first. But yeah, I'm always happy to kind of talk through stuff.
And I just want to give a shout out to your YouTube channel. I know it's a little bit young for you, but
It
I like, I love it. So tell
is.
people a little bit about that.
Yeah, so I have I've been running my own practice for 7 years, 6, 7 years, and I have been slowly adding to this YouTube channel and recently have been really getting on it. And what I almost was debating saying is like I would like to develop some online kind of curriculum so people can figure out where their core is without having to necessarily get evaluated, though sometimes it's hard. So that then you could figure out, okay, I'm at this level, so these are the exercises that might work for me. Because what I tend to find is that people are, this is something I should say out loud. The strength and conditioning world thinks that your core is at least a 3 out of 5. Almost everyone who comes to me with some kind of chronic complaint is closer to a 1 out of 5. So that means that most of those exercises are completely inaccessible to you. Like you're going to try them, but they're not going to feel probably like your core. They're too hard. So yes, you could look at my YouTube channel, which I don't even know how you find. But I do have a ton of videos and a lot of, I need to like sprinkle in more, but the core is usually labeled by like level 1, level 1A. And so if you're suspecting that maybe you need some lower level core work, I would say that the general kind of like exercise world doesn't show a lot of really, really easy core work because they assume that you can do it. But I start people on, heel slides and things that are really, really simple movements, but are sometimes very, very challenging. So that, yeah, the YouTube channel has a lot of little exercises. And yeah, just like a collection of things, as well as my website has a blog that I also think is sometimes helpful if you're kind of just like wanting to hear about why I would give a certain exercise. I try to kind of like give a quick soundbite on like, if you're having knee pain, this might be good. Probably not surprising. I think all of it ties back to the core. I think everyone underutilizes core, but I have some other things that sometimes help.
Perfect. I love it. Well, thank you again so much for being here. We will do this again, get deeper into some of these things, and I'm so appreciative of your work.
I hope the interview was useful to you. If you liked it, subscribe to the channel, subscribe to my blog at healmybelly.com, and tell a friend. I look forward to seeing you again.